Okay, so now we're talking about a little bit more of the advanced ventilator therapy, a lot further beyond than just basic terminology and basic numbers. We're talking about what to do when you have a patient who's decompensated and has acute respiratory distress syndrome, and what you can do with a ventilator to begin with. So this would be a scenario within our current pandemic with COVID where a patient is showing that they're more hypoxemic, requiring more oxygen. Oftentimes we're seeing on the floors that patients can go from 2 liters to 4 liters, and then once they start getting towards 6 liters and above, we're starting to get concerned that that patient's going to need to be intubated. This is a little bit more rapid than what would normally happen because of the current milieu that COVID is creating and the rapidity with which COVID can cause decompensating hypoxemia. So this would be maybe an example of a patient got to 4 liters, maybe 5 liters, maybe 6 liters, are transferred to the ICU. We watch them, they continue to climb, maybe at 8 liters per minute. And now we're thinking, okay, we better intubate early because we're seeing a rapid decline. And once that would happen, a patient would be put on a ventilator and they would be severely hypoxemic. So we would start with the ARDS protocol. Once again, acute respiratory distress syndrome is ARDS or ARDS. And I'll just review the 3 criteria real quickly. Once again, you should have bilateral chest X-ray infiltrates or kind of whiteout on both sides of the lungs. You should have a degree of hypoxemia that has a varying degree of severe. Many of our COVID patients have severe PF ratios, sometimes even below 200, 150, or 100. But to meet criteria for ARDS, you need to have a PF ratio below 300 for at least mild ARDS. And then the third is an exclusionary criteria. It can't be from heart failure, fluid overload, pulmonary edema, and a cardiogenic source. So non-cardiogenic pulmonary edema is what we're talking about. Okay, so you've defined that. Let's say you've got a patient who you intubated, and the first settings that you're gonna see is a volume. So we aim for 6 cc's per kg of ideal body weight. So as we grow more obese, our lungs don't get any bigger. So this ideal body weight is based on us being nice, thin, and healthy. And we start off with a tidal volume such as this. So if we had a 70 kilogram man, multiply that by 6, we come up with 420, but we'd say a volume of about 400, okay? So the FiO2, we're often putting on 100% because they just got intubated and we want to get that oxygenation up. And now we have an endotracheal tube in their trachea to be able to deliver it. Respiratory rate, we can start at 16. Maybe if they're having a little bit more problems with acidemia, we want to get that carbon dioxide off a little bit. We could go up higher, but you'll see in ARDS, we don't care so much about ventilation and PCO2 because that's not the driving force that the patient is most at risk from or could have a more lethal effect is the hypoxemia. So PEEP, we'll say maybe we start at about 10. This would be sort of initial settings for an ARDS patient that came in. This certainly could be higher, this could be changed, but this would be something that we would be looking at for a patient with ARDS. And then we would start to dial down the FiO2 as we got our blood gases back, took a look at the PF ratios, and took a look at the oxygen saturation. We're wanting to keep that oxygen saturation above 88% roughly to be able to help this. So just quickly, a brief change that you could make if somebody's blood gas came back at 7.32 and we'll say their PCO2 is just a little bit elevated at 51, but their PaO2 is quite low at 53. We'd like to keep that above 55, above 60 in ARDS. Then we could start saying, okay, we might need to go up on the PEEP, and that would be the first change we make. And then perhaps over time, because PEEP changes can take a little bit of time, maybe even up to 30 minutes or 60 minutes, we would watch this. If our next blood gas came back 7.33, 50, and perhaps 71 now, and we're above our PaO2 goal. Once again, this is pH, P little a CO2 from an artery, and Pa little a O2 for these numbers. If we got to this point, we could start saying, hey, we can come down on the FiO2, and we might make that in increments of 5 or 10%. So maybe come down to 90%. We keep getting these blood gases and following them, or following the SATs and seeing where we could go. So this would be initial settings for somebody who's on volume control and has entered into ARDS, and then we start changing these and adjusting these.